Wonderful. So Ben Gatehouse is a clinical nurse consultant who works with Northwest Mental Health Service. Jump in, Ben, if I misrepresent.
Thanks.
I have recently met Ben because we have a specialist dementia care unit opening with VMCH, which is, I suppose, a type of transition support for people with really advanced dementia, tier 6 and 7, who cannot be supported in mainstream memory support units. So the idea is that they will be supported for up to 12 months at a time, each person for up to 12 months. And we will have clinical in-reach support from the team that Ben is involved in. So that includes clinical nurse consultant, consultant psychiatrist. We have employed an RN specifically for that unit, a GP that we have sourced who has dementia expertise specifically for that unit. And it's a higher ratio of staff and really intensive clinical and behavioural support to try to help stabilise some of those really challenging, I guess, expressions of how the person is experiencing their dementia. So it's really exciting to have that clinical expertise involved in this program. We are yet to open because the facility is based in Sunshine and has had a number of COVID cases or exposures, and they've gone in and out of lockdown quite a number of times. But opening is imminent now that COVID seems to be settling, fingers crossed. Hopefully we're coming out the tail end of stage 2, stage 4 restrictions, the second round of COVID. So I've asked Ben to come along today to speak about mental health and dementia, because that has been something that came up a lot in our first meeting a fortnight ago. So how do we support people who are living at home, both the person living with dementia who might be experiencing a lot of added difficulties and additional confusion and disruption to their everyday routine, and also the family carer who's likely to be experiencing some additional stress and carer burnout themselves. So Ben's kindly agreed to come along, and we're hoping the session will be quite interactive. So please do ask questions. But yeah, we thought he'd be quite appropriate as a person to come and talk about his experience and expertise in mental health and dementia. So I'll throw over to Ben. Thank you, Ben.
Thanks, Elizabeth, very much for that introduction. And look, it's terrific to be able to meet everybody virtually and have a little bit of chat about dementia and mental health. And perhaps as I'm talking, there might be questions or scenarios which you might like to throw back at me, and we can have a bit of a chat about them. I'm a registered psychiatric nurse, and I think one day I'm going to be unemployed because I pigeonholed myself very early on in my career into dementia, and that's all I've really done for the last 20 years under a mental health umbrella. So I really have pigeonholed myself into that space. But I remember a story from a true expert in dementia. You might know Bernie McCarthy, a very well-known Melburnian who's developed his own business in dementia education. But he told this very brief story at a conference once, and it was very memorable for me. He said when he first started working in dementia care, as a much younger man, he thought he knew this much about dementia. And after 25 years of working solely in dementia, Bernie said, I now realize I know about that much. And I kind of feel the same. I think I was in my 20s, I thought I knew a hell of a lot about dementia. 20 years later, I'm beginning to scratch my head and think there are no experts, and we're always continually learning. And sometimes we don't know the right thing to say or do when we are supporting people with dementia. So I think part of our support for carers is to actually empower them to understand that sometimes it's very difficult and sometimes there is no exact right answer or right response. And that even people who have worked a long time just in dementia care don't always know the right thing to say. I did jot down just a few points, and again, apologies if this is nothing new that you haven't already heard before, but if I could summarize what I've learned about dementia and really good support of people with dementia in supporting their mental health in about 10 very short points, this is how I would construct them. I think the first point, and I learned, my last job before this one, I covered 51 nursing homes around Australia for a very large for-profit aged care provider. And a few things that I learnt along that journey is maximise choice, minimise control. So it sounds really simple, but the mental health of people with dementia is improved if we can give them as much choice as possible and we can minimize control. Now, obviously, if someone wants to fly to Paris or cross 8 lanes of the Monash Freeway, sometimes we're going to have to say no. I get that. But as much as possible, we promote choice and we minimize that control. And the language that we use is really important, because sometimes what I hear is people saying, stop that, put that down, don't touch my ornaments. No, that's not the kettle. And it's command communication, and it doesn't support the person's choice as much as possible, and it corrects them. And when we correct people with dementia, it dints their mental health. Because if someone says, Ben, you're wrong, my self-esteem, my ego is dinted, and I don't feel as good about myself. So very simple language for people, carers, either undermines people's living with dementia mental health or supports their self-esteem. So if Frank thinks it's Christmas tomorrow, my suggestion to his wife or sister or daughter would be, you don't need to tell Frank that it's Christmas in 3 months' time. Because if Frank, and by the way, Frank's not playing games. He does think it's Christmas tomorrow. But when we correct people and try and reality orientate most people with dementia, it does not help their mental health. It makes them annoyed, frustrated, more confused, and it doesn't help their general well-being. If Frank thinks it's Christmas tomorrow, I'd be saying we really should go into the garage and see if we can find that Christmas tree. And what do you think your grandchildren might like for Christmas? So it sounds very basic, but I'm always surprised at how many family members and carers haven't been told these very basic communication strategies, which either empower a person with dementia and support their self-esteem and their reality, or whether it undermines their well-being. The other thing I'd like to talk about just very briefly is behaviours. So 70% of people with dementia at some point during their lifespan will have a challenging behaviour. It might last 2 weeks, it might last 2 years. But most people, unfortunately, die of dementia within 8 to 12 years. Unfortunately, it's a fatal disease. Some people live for 20 years, some people live for 18 months. But 8 to 12 years is the ballpark figure. During that period, most people will have behaviours. The one message I talk to carers about, again, it supports people's mental health, because when I'm aggressive or when I'm agitated, my mental health is really poor. So if I think back to the last time I was really anxious, for that 2 hours when I was really anxious, my mental health was appalling. So our staff and our carers' ability to be able to manage behaviours is really important. And the one message I talk to people about is people behave for a reason. People behave because they need something. Dementia is never the reason why Frank became anxious, aggressive, or threw his plate through the window. People always behave for a reason, and it doesn't matter if you've got dementia or not. So once our staff and our carers start thinking about, Mary behaved in that, Mary is getting anxious and starting to yell, what does she need? That's my message to staff members over many years. What do you think she needs? Why do you think she's angry? And again, when we tell people to stop that, calm down, it doesn't support an understanding of what they actually need. So people, like everyone else, but those living with dementia, become angry for a reason. What the research says, and this is Hammond Care research, they surveyed 700 people in nursing homes. And again, whether a person with dementia lives in a nursing home or the community, I don't think it matters too much, to be honest. But they surveyed 700 people in nursing homes in the last couple of years. And the two reasons why people become aggressive or agitated or highly anxious is pain is number one. So we must be thinking about, is this person in pain? We've asked them if they're in pain and they've said no, and they don't show any facial expressions. Pain is chronically undertreated and undiagnosed for people with dementia, and it is the #1 reason why people become aggressive. So we always must think about pain. And the second reason is care approach. How were they spoken to? Were they given choice? Was their autonomy respected? That's the other reason why people become highly agitated, because if there's one fundamental cliche that I've heard over the years that is, in my opinion, completely and utterly wrong most of the time, and that is people with dementia like routine. In the very first early stages of dementia, maybe people like a routine. We go to church on Sunday, then we come back and we see Mary for a cup of tea, and then we go to bingo at 4 o'clock, and then we have dinner at 6. That works in the very early stages of dementia. Very, very quickly, I would strongly propose a go with the flow mentality for people with dementia. So we might have a plan for this afternoon or tomorrow morning, but let's be highly flexible in regards to what shape tomorrow morning takes. Because as everyone I'm looking at knows, people with dementia's demeanor, mood, behaviors and personality traits or personality aspects can change from hour to hour, from day to day. And what I find is that carers become really, really frustrated, and they feel increased burden because someone has told them, you must stick to a routine for Frank. And they've got this on their shoulders that we must do certain things at certain times, otherwise I'm not being a good carer. A good carer is going with the flow of the person with dementia and having a flexible routine. And when you don't, the carer puts more stress on themselves, so their mental health suffers, and the person with dementia is more likely to become agitated and aggressive, and their mental health suffers as well. So try and reduce demands on people with dementia is really important. The other really important aspect, and it sounds like common sense, but I think particularly at the moment during COVID, I think it's something pertinent that we all need to remind ourselves of. And I remind myself of this too. I just did 2 weeks because the SDCUs have not started quite yet. I just spent 2 weeks at the hospital, in the mental health hospital up the road here in Sunshine. And what I was reminded of is when I'm not at my best, I can't be the best carer for my patients. So if I haven't had a good lunch, or if I haven't drunk enough water today, or if I haven't slept well last night, or I'm not managing my own stress levels, my patients or my clients don't get the best of me as a nurse. And I think we have to remind our carers and our family members that if they are in the best condition possible, they can be the best carer possible. And the cold hard reality is, if you're tired and you're stressed and you haven't slept and you're not eating well, your intentions can be fantastic, but I guarantee you, your compassion, your empathy, your patience, your communication will not be as good than if you're in your ideal situation. So I think we just need to remind carers to get themselves in that ideal situation, and then they can provide the best care. I think the last point I'll make is about the environment. I think there's obviously a piece about the environment, and how does the environment either support people with dementia's mental health or makes them more irritable, grumpy, and confused. And we all know about stimulus, and we all know about signage, but I think it's really important that we understand that when people have dementia, the physical environment either supports my autonomy or diminishes it. And if you could think just for a second, if you really needed to go to the toilet, like really needed to go to the toilet, and you couldn't find the toilet, how would that affect your mental health? You know, irritable, grumpy, highly anxious. So sometimes people are banging down doors. They can't always communicate, but they're banging down doors because they need to find the toilet, or they're worried about their car. So that person doesn't need PRN medication. That person needs to know where the toilet is, or that their car is okay. But signage and wayfinding ability, again, helps people's mental health. Because if I can find the toilet, my mental health is improved. So carers in their own home should be thinking about how easy is it for Frank to find the toilet, to use the taps. The kitchens of the future for people with dementia, for example, I can see Elizabeth's white cupboard in the corner there, some of the kitchens in the future, that will be a glass cabinet, so that if Elizabeth develops dementia and she's living in that unit, she'll be able to see the plates and the glasses behind that cupboard. At the moment, it's a white cupboard and I can't see it. So there's lots of ways in which the physical environment actually supports the mental health of people with dementia, whether it's finding the toilet or finding the plates which are behind that white cupboard. The carers who this is the last point I'll finish on. The family members, in my experience, who can care for the longest at home with their loved one living with dementia are the carers who can embrace that highly flexible, go with the flow, we'll see how this afternoon goes, and I'm not going to get stressed if we don't make it to the doctor this afternoon at 3:35. So I think it's important to reiterate to your carers as much as possible to have that mentality for their own well-being, but also for the person living with dementia, about that flexibility about how today goes, and that the house and that, you know, the sock drawer and the ornaments will become touched and messed up, and how well can you cope with that? Over to you. Thank you for listening. Any questions that sprung to mind, or any situations that sprung to mind as I was having a ramble then?
Thanks, Ben. I think Wendy had her hand up. Did you have a question, Wendy?
Oh, I was clapping at the idea of fridges with glasses because, yes, it did bring up, I had an elderly lady across the road who brought up 6 kids, husband and wife, lost her husband, a couple of years later developed dementia, and her adult children, I've got a really bad personal home phone. I only get one phone call from one person on it. It really needs to go. But anyway, the family bought her this same cheap phone. And I find it hard to actually get the right numbers. It's just a cheap, revolting phone. So in chatting with the family, I said, look, you know, I noticed she's got the same, because she would come over to me because she couldn't get the phone working, you know. And I said, I've got the same phone. It is terrible. It's hard for even me, you know. So, and then I told them about the KISS phone that was available, where you could just have the names enlarged or 5 photos of her children or whatever, you know. So and that would have helped. I was so sure, without being an expert, but, you know, so sure that would have helped her not deteriorate as rapidly. Yeah. But they didn't do it. And I just felt like that was actually quite criminal, that those sorts of things that we know make lives easier, like coloured doors and taps, and I just don't understand actually why they're not sort of put in place. I do understand when it's family and it's ignorance, and you can't say you're actually helping the deterioration along here, you know. Would you like to help your mother? Or you know, I don't know how, other than introduce to wonderful services, you know, Dementia Australia, Bernadette, and all that sort of thing, to help educate them, you know. But it's very hard as a community neighbour, you know, in those scenarios. But anyway, so yes, that was the story that came to mind. So that's why I clapped at the fridge. I thought that would be wonderful too.
I'm also a big fan of the orientation clock too. So there's some fantastic orientation clocks, which so the 2-week stay I had in hospital, there was a patient getting up overnight to ask the nurses what time it was. You know, a really good dementia-friendly orientation clock would have improved that patient's quality of life, because she would have looked at the clock, seen it was 4:21 a.m. and probably gone back to sleep. Instead, in the hospital, she was getting up and asking the nurses what time it was. You know, classic example of how we can use very basic resources to help people's quality of sleep and quality of life.
On that point, can I ask, is there a phone, because the KISS phones, or the KISSer phones, I think they don't have the capability to do video calls, you know, like you can do FaceTime on smartphones. Is there a phone yet out there that is simple, like the Kaiser, or I'm not sure how you pronounce it, phone, but also does video? Because the FaceTime would be wonderful I haven't heard. Has anyone heard of that?
Not sure.
No.
No. I think, Wendy, as people get older, those really small phones are too small to use. They're actually better with a small iPad. They actually can't push the buttons, even if they have got the screen on it.
Yes.
So
Okay.
the large, you can get the seniors phones, which are a bit larger, but I still don't think they have a video capacity.
No.
So yeah, it is a tricky one.
I was just going to say about the carers, the highly stressed and anxious carers that just can't go with the flow.
Yeah.
So I had the situation yesterday where they were arguing between each other, and she washes the dishes after him. They're not clean enough. And she was saying that to me in front of him. And then they were arguing. And she's highly stressed but can't let go that it's not as clean as what she wants it to be. And the other thing a lot of carers will comment about is, how am I supposed to look after myself when I haven't got time? You know, So how do you talk to those ones, Ben?
Look, time. Yeah, it'd be great it'd be good to create some more time, wouldn't it? I guess there's sometimes. And look, sometimes you need 3 hours by yourself. I'm guessing, sometimes you need half a day or 2 weeks respite. But I guess emphasizing or illustrating that sometimes 6 minutes or 5 minutes of relaxation or meditation can actually help my well-being to some extent. It doesn't have to always be an hour block or a 3 hour block. Sometimes just grabbing those moments when you can. It might be 5 minutes to play my favorite music. I mean, as opposed to having a long period of time. I think Deborah, just in regards to that first point, in regards to that carer, I mean, she washes the dishes. Having an argument with a person with dementia is just, as we all know, that's just crazy. And some carers have the ability to adapt their communication style and their behaviour. And we all know that some carers are really stuck, and it's really awful to see when they are stuck, because they have arguments with their loved one, and they wash the dishes in front of them after the person has just done them. Now, if we had done the dishes and our partner washed them straight after we'd done them, how would we feel?
Exactly.
So it's really sad to hear those situations where people's mental health living with dementia is undermined because carers either haven't been taught or they've been taught and encouraged, but they can't change their behaviour.
And even with her, I was talking to her yesterday, so to start the personal care. And so while someone's helping him shower, you can actually sit down and have your cup of coffee. But she couldn't, then came up with all these reasons why she couldn't even take that half an hour while someone helped him to sit down and look after herself.
And that's, Ben, that's in line with what Deborah has just said, is in line with what we discussed in this first meeting we had a fortnight ago, in that a lot of different providers stated that they'd found the person living with dementia at home seemed to be coping a little bit better than their family care partner with this whole COVID situation and the restrictions and the isolation. And I wondered if you had any advice for family carers who maybe couldn't recognize themselves how incredibly stressed they are, or how short-tempered they're being, or, if there's a way of kind of engaging with someone who, as an outsider, you can tell they're not as well mentally and emotionally as they could be. Any strategies or ideas that we as providers could potentially introduce into that?
I think it's really about being able to self-reflect and be in touch with how you're feeling and how you're coping, and your level of patience and tolerance and coping skills. And I think there's a couple of key points to illustrate to carers, and that is that's on a continuum. And every morning, afternoon and night, that's changing for all of us, whether we're in a caring role or not. Our mental health and our well-being is constantly throughout every minute of every day shifting slightly. So I think that's one message to carers, just to be aware that, this morning will be different to tonight. So if you were feeling absolutely terrible this morning, that things might be changing. Or might be different, and that a very simple 1 to 10 or 0 to 10 scale, so they can actually rate themselves And then if I'm a 3 or a 2 or if I'm under 5, then the person has, these are the strategies I put in place if I rate myself from a 0 to 5. And if I'm a 5 to 10, this is what I continue to do. So there's kind of a very simple, it's not a flow chart, but it's a simple a diagram where 0 to 5, and I empower myself to take these actions. It might be to have extra cups of tea in the garden during the next 24 hours, because that's where I actually find my peace and relax, or I take the dog for more walks, or I make sure I go to bed an hour earlier if I can every night. But I think if you break it down, in what we're trying to do is encourage our carers to be really in touch with how they're feeling, because the busyness of the carer that Deborah was describing makes me think that carer was in no way, shape or form in any personal space to ascertain how she was feeling and managing, because she had 101 things to do and I couldn't possibly sit down for 5 minutes and relax. So it's encouraging our carers to take a couple of minutes to self-reflect about where they are on that mental health continuum, and give themselves a rating perhaps, and then have some strategies that they employ. They may not feel like employing the strategies, and that's the trick. When you're depressed or when you're anxious, you don't actually it's hard to behave as though you're not depressed. When I'm depressed, I find it really hard to exercise. But if I'm conscious of the fact that my mood is going lower, I'm going to try and empower myself to exercise because I know it's good for me. So healthy behaviours when I don't feel like it. But I think a 0 to 10 scale for carers is a simple way to help them understand where they're at and what they can do about it.
I think it's interesting conversation, because it also begs the question, often when you get your couples connect with your services, the person who's in the caring role can have a pre-existing anxiety or depression issue anyway, or other mental health issues. Like they don't come in, they come in as a package.
Yeah.
And you take the dementia out, there's already issues there. And so if it's been the person with the dementia has been the one who's been caring for the partner in whatever their health issues, particularly mental health, who really got to work a lot harder to help them put in strategies that will be effective.
Yep.
And that's not uncommon.
No. And coming from a psychiatric mental health background, the one bit of research that I always remind myself about when I'm talking to carers is that what the research says is you recover best from mental health illness if you're just not relying on medication. And there's a lot of people out there who think if they take their antidepressant or antipsychotic or anti-anxiety tablet, I'm doing all I can for my mental health. The research says if you have a multi-pronged approach to mental health, it gives you the best chance of the fastest recovery.
Can I just ask a quick question? Oh, sorry.
Paul?
Just that what you were saying before about checking with the carers, the scale 0 to 10, is there such a actual algorithm or flowchart in existence already?
There's lots of mental health scales out there where people can be assessed, and I'm sure there's huge amounts of carer stress rating scales out there. But I wasn't referring to one in particular. But I know there's a lot of models and scales out there for carer stress. But I think we don't necessarily want to burden our carers with anything too complex or burdensome, but create a very simple understanding of where are you today? You're a 2. Okay. So when you're a 2 out of 10, what are the things we talked about that you'll try and do in the next 1 hour? It might be a 1 hour plan, or it might be a 12-hour plan. Because something on the fridge or in the bedroom where they can refer to that, I think is useful. I'm surprised.
Yeah, that's what
Sorry.
Yeah, actually, sorry, that was my question. Like, what to do if you're a certain score? Is there such a template already, or?
No, there's not. Well, there's not that I'm aware of. And I think importantly, all the things that keep us mentally healthy is extremely individualized. Because some people find walking the dog stressful because they're scared the dog's going to break the lead. Right. So whereas other people love walking the dog and find it stress relief. So I think it's to use a bit of a cliche, it is that person-centered approach about. But it helps if carers self-identify what promotes their mental health.
Yeah.
I think, like you're saying, that first point you made, Ben, about maximum choice, maximum control. If I set something like that, I sit down with the client and draw up how are we going to do this ourselves. You might draw a ladder, you might just put the numbers. You get them to draw whatever they have in their visual image. Then they take ownership of that too.
Yeah.
Rather than, as you say, just hand out another form that they don't, because they don't work well with pre-prepared forms. They just get lost. Lost.
Another thing to do.
A question. Oh, sorry, did someone else have a question?
No, you go, Bernadette, that's fine.
I'm curious about, with your mental health background, psychiatric mental health, because the other side of the coin, and I'm getting a few at the moment, are people coming in with a new diagnosis that have a pre-existing mental health issue as well. So and they're very tricky to try and work out, well, what is the dementia symptoms and what are your mental health issues? Because they're very similar very often. So do you come across some of that, or do you work with some of that as well?
No, I do, Bernadette, and there's actually medical terms. Pseudo dementia is a very common one, where the person is actually depressed, but they're presenting with dementia. Because when you are depressed or when you are anxious, your memory, your concentration, your whole cognitive skills don't work as well. And the interesting research is, and I don't think they know why, but if you have depression through adult life, you're at a slightly greater risk of developing dementia later on in life. But you're right, people develop dementia and have had pre-existing mental health issues. And I think it's important, and it's really hard for people like myself to think, well, is that depression or is that anxiety? And GPs, with all due respect, are often not experts in mental health or dementia either. So I think it's just being aware that psychiatric illnesses can coexist with people with dementia. In fact, if you have dementia, you're more likely to have depression, anxiety, psychosis, paranoia, suspicion. So it increases your risk of having a mental illness. And I think the best we can do is help our carers just be aware of that fact, and that sometimes medical or psychiatric consultation and support is required, because the two can coexist. In fact, it's more likely they coexist if you have dementia. Which again is a confusing picture, but depression is extremely common with people with dementia, as is anxiety, and sometimes a little bit of medication can be a part of that jigsaw puzzle to help the person recover.
Well, certainly I've got a few at the moment with bipolar, PTSD, DID, all sorts of other quite long-term mental health. And then, sad to say, they end up with a dementia diagnosis as well. So life is not easy.
No.
Not easy.
One point I just would like to make extremely briefly is, and it pertains to mental health and people living with dementia's well-being, and that is what I encounter a lot in community and residential care spaces, and that is people with dementia being bored and having nothing to do, and being told to sit down and relax, and they don't feel useful, productive, or worthwhile anymore, and that really affects people's mental health. So the message there, obviously, to our carers is, mum can't make a roast dinner anymore, we know that, but the reason her behaviour is that she keeps walking to the kitchen is because she still wants to feel useful, wanted, and productive in the kitchen. So maybe a carrot and a peeler, and she can peel the carrots. And you know what? If she keeps peeling the carrots until there's no carrot left, that's not the point of the exercise. The point of the exercise is mum feels useful, wanted, and if the carrots never end up in the oven, that's fine. And again, I don't think carers understand some family members don't understand that people with dementia still want to be useful, productive, and it's really good for their mental health.
Just on that point, I really wanted to, I like the language you used very early on when you were speaking, Ben, about, and I'm not sure how you termed it, but using positive language, not using, not telling people off. And that's something we work really hard with our volunteers and staff at Caledonia, is to to, if somebody's about to tip their cordial, for instance, onto their meal, instead of saying don't or stop, we say, oh, could I pass you the sauce instead?
Right.
And it doesn't matter. We'll, you know, if the meal gets ruined, we'll get another one. It's not an issue, but at least nobody's being told off for
Fantastic.
the
Great to
things
hear.
they're doing. And yeah, that's part of our training package. And I didn't, what was the term you used? You said it was?
Well, sometimes it's command communication.
That's
Stop, don't do that, that's wrong, come here, that's not your seat.
Yep.
It's always command communication, which takes all the choice away from the person, and reminds them, unfortunately, that they're doing something wrong, they're hopeless, and they've got dementia. So it's fantastic, Sarah, to hear that your staff have that ability to support people and not emphasize their deficits.
Yeah.
Because when you tell someone you've poured the cordial onto their meal, you're just emphasizing they've got dementia.
Yep.
Why would you do that?
Yeah. I really like that. Now I've got a term for it. It's good.
Yeah.
I noticed, I mean, you know, hospitals really don't always manage dementia terribly well. I'm being kind in my language there. But I was just, the hospital unit I was on, at mealtimes, they presented people with dementia with the full hospital tray. So there was about, not exaggerating, there was at least 6 to 8 items on that tray. There were desserts, there was sweets, there was packaged orange juice, there were knives and forks in a package. It was the most confusing tray. No one had actually thought the reason why that person's not eating or is fumbling or getting frustrated or is walking away from the dining room is because that tray of food is completely overwhelming the person. And that's the reason they've gone back to their bedroom. And then the person becomes, oh, they're difficult, they won't sit down, they're not eating properly, maybe they're depressed, they're socially isolating. You know, sometimes it's because we've completely overwhelmed them with the tray, the hospital tray that we've put in front of them, as opposed to one dish at a time. Keep it simple. And not every person has heard that message before. I was really surprised in the hospital that they were still doing that, and we're in 2020.
One of the things we also talk about, I guess, is knowing your people really well, and also knowing perhaps some of people's idiosyncrasies and quirks. One of the things we use when we're training is we talk about, you know, there's a whole lot of women who use public toilet facilities by putting paper on the seat or trying to flush with their elbow, or, you know, we've all been taught different ways of doing things, and things we do very privately that no one would know about. For instance, I don't know why, but I eat meat pies with a teaspoon. I take the lid off, put some sauce inside, and eat the meat with a spoon. Now, if I get put in a nursing home with dementia and I'm demanding a teaspoon for a meat pie, that's going to be difficult behaviour. Why don't I just eat the meat pie properly, like a grown-up? And it's just knowing those little idiosyncrasies and taking the time to look into them for people. Like you said, Ben, why are they behaving like that? What do they need?
I think that's a fantastic point, Sarah, and probably the true crux of the issue about how we support people's quality of life, mental health and well-being. And you've summarised it nicely about really knowing the individual, which is, again, the essence of person-centred care. There was a story about a man who was admitted to a nursing home, and he would not sit, I think it goes that he wouldn't sit down at the dining table. So he had a whole lot of behaviours because staff were trying to get him to sit down at the dining table and have his meal like everyone else. And there were 2 female staff members, you know, just about had their shoulders on his arms trying to get him to sit down and have a meal. And it was only until he couldn't talk properly. And it was only until they learned, as you've rightly said, about who he was as a person, and spoke to his wife. And she said, well, he's always been an absolute gentleman throughout his life. He would never sit down at the dining room table until all the ladies in his company had sat down first. So if the nurse, and what happened was, of course, the female nurses sat down at the dining room table and he went straight down. It just illustrates that knowing the person helps in so many ways. really hard to provide excellent care to a stranger.
Yeah.
You can be
Yeah.
polite, you can be dignified, you can be respectful, but really hard to provide great care to a stranger.
Thank you. Very interesting. Did anyone else have any other questions for Ben or any scenarios they wanted to run by him while we've got him? No? Thank you, Ben. I think that was really helpful. Some ideas and sort of concepts that I think a lot of us are really familiar with, but it's good to sort of, I don't know, rehash some of the concepts with examples. I think, you know, thinking of individual clients and families and couples living at home, it's really good to, you know, prompt us to go back to families and maybe present some ideas that we perhaps assumed that people might have already had, when, as you say, not everybody understands or knows these concepts. So thank you very much appreciated.
Not at all, not at all. Thank you, everybody. I'm going to say goodbye, but thanks very much for the invitation, Elizabeth and Sarah. And as I said, I probably reiterated a few things that everybody in the audience already knew, but sometimes it's good just to know that you're on the right track and you're saying and doing all the right things. But thanks again for listening, and nice to see you, everyone, and please keep well.
Thank you.
Thank you very much, Ben.
Your meeting continues and I say goodbye, I think. Is that right? Or
Yes.
do you all end
Yes.
now too?
Yes.
Okay. Bye, everyone.
Bye.
See you. Yeah.
Right, Sarah, shall I throw to you? You happy to?
I wanted to just add one more thing to the tail end of our meeting. Part of what Elizabeth and I talked about when we planned this, hello? Network, and we were talking about sort of what colleagues we would invite and who might be interested, was actually sharing across funding streams, across organisations, and making that referral pathway easier for people living with dementia and their carers. So in that vein, I'd like to just, and I know some people know this, but remind people that on Caledonia's website are now many activity packs in a PDF format for anybody to download and pass on to their clients. They are specifically designed for people living with dementia, but they're probably useful across the community as well. So every time we make a new one, they go up on our website. We also have a YouTube channel, which now has 120 jokes of the day, that one of my staff members is doing every day. And that gets sent out obviously to all our clients, but I'm more than happy to share that YouTube link with everybody as well if they wanted to use it with their own clients or carers or groups or whatever you'd like. Caledonia is still running carer support programs, and now that we're all on Zoom, it doesn't have to be local referrals. If people want an extra support group, you're welcome to put them in touch with me. I just wondered if there was anything else anybody would like to make available from their own organisations.
So just on your last point there, did you mean that if you had a group of carers, you would facilitate a new group for that group? Is that what you meant? Or just joining the ones that you're already running? I
hadn't thought of doing that, but that's certainly not out of the realms of possibility. But at the moment, if they were single carers, we're more than happy to accommodate them in the groups that are running at the moment. And they're actually running fortnightly because they wanted more contact with each other.
Yes.
And
please just,
sorry.
I was going to say, please just shoot me an email.
Yeah, on that topic, Wendy, last meeting, the first meeting a fortnight ago, we did raise the idea of potentially trying to connect some of the, people living with dementia and or their carers across these organisations. So across, the people who we are representing, I suppose, in coming together. If there was a way of us hosting a platform or trying to just...
Sorry.
That's, I think, the grandson of one of my volunteers logging in a day early to afternoon tea.
So I'm not sure if anyone feels there is a need for that or has any ideas about how we do that, but there obviously is a huge advantage and benefit for people in, you know, that peer support approach, whether that's just people catching up for a virtual coffee or, you know, small scale groups, or whether we can facilitate something for them. I think particularly during COVID, it seems as if there's, you know, real genuine isolation being experienced by a lot of people, particularly those living with dementia and their families. So maybe that's something we'll just leave almost on the agenda and keep discussing each time to see if there's been any interest, or whether we can float the idea to some of the people that we're supporting. But otherwise, there are a lot of virtual carer support groups continuing. So through Caledonia, Dementia Australia, you know, Deb and Carrington Health, and probably a lot of other organisations are still continuing in their groups. Good.
So Elizabeth, Villa Maria's not got their carer support group?
We do. We interestingly didn't get the same uptake from our, you know, dementia carer support group participants. I think because of the way that it had been operating, it was very much a private space that people would come to and vent and offload, and it was just the family carer, not the person living with dementia. So now that they can't step away, if they have, you know, the person living with dementia right next to them, it's a very different dynamic. And there are carer groups running, but not that one in the same way. So it's more activity based, you know, art therapy type sessions, or, you know, some kind of practical element has been introduced rather than just meeting together as a group of carers and venting. But on that, Deb, Sarah mentioned, and I think some other organisations might be doing something similar, where a volunteer or a staff member can phone the person living with dementia and keep them entertained or engaged in who knows what type of conversation for whatever length of time, to free up, you know, the family caregiver to attend some type of online session, or do the housework, or take a shower, or go for a walk in the garden.
So on that note, if a carer did want to, say, have a counselling session with Dementia Australia, would they be able to have a phone call from, how would I organise for them to have a phone call from someone that engages with the person they care for, so that the carer can have a counselling session or just a conversation with somebody? Bernadette, Elizabeth, Sarah?
That's a great question, because I was going there too.
Well, at the moment, let's trial it. Why don't you give me a ring and we'll try and set it up with one of the Caledonia staff. One of the challenges for them has been that there's 17 of us, there's 20 of us actually, and everybody has been very hands-on their whole working career, and suddenly trying to connect with people remotely has been a real challenge. But my staff are loving telephone conversations. We're also phoning for how many, about 58 Eastern Volunteer clients regularly as well. So if you wanted to try booking in a conversation for someone to free up the carer, give me a call.
And also our carer support program could offer the same type of support. Yeah. I did raise it with one of my managers late last week in how we could potentially set up a program. Yeah. And there are a few teething issues around what funding would it sit under, how's it going to look, how are we going to train people to ensure that conversation is appropriate and sensitive. Obviously, it can't just be any Joe Blow phoning a person living with dementia who doesn't know the person, you know, as Ben touched on. You really need to have some understanding and information about who that person is to make it meaningful and engaging.
All right, so another question back. We're getting a lot of YOD clients. I think they're the only ones still getting diagnosed. All of my older clients are on wait list till it's face-to-face. But there is a need for more YOD carer support groups. So two questions. One to Deb, is your YOD group still functioning on Zoom at the moment?
Yes, yeah.
Okay. and I have referred people, I don't know what they've done, but it could also be that if Sarah's got some, running regular groups, would a YOD group be something you might consider as well?
Yes, most definitely.
That sounds very good to me. We have a new team leader who's over our NDIS YOD group, Renee, I've forgotten her surname, a German name, but she's was a RAS at Stonington Council, so she comes with a lot of experience. So once she gets her head around all of our stuff, which is just huge, she's, I think, going to be quite proactive in working in the yacht space too. So that'd be really good. So I think we need to keep talking, don't we?
Absolutely.
Yeah, we do.
We do.
And
I like that idea.
In the meantime too, if you want to refer anyone with dementia who could handle Zoom bingo, Zoom conversations, social group on Zoom, those are already running and we have the capacity to run more.
Right.
But we don't have the capacity to get into people's homes and train them to get on Zoom. It would have to be someone who was already available. I said in a forum this morning, if I had a crystal ball, I would have implemented, learn about iPads about 18 months ago and made sure everyone was connected, but we didn't have the benefit of that.
No. Look, that's something we've done surprisingly successfully. We've got a few staff members who their particular role is not busy because they're not face-to-face, and they're doing individual, basically IT support. And we probably had an uptake of, I would have said 80% of our clients actually being able to access Zoom groups. We're running our Living with Dementia on.
Fantastic.
I'm amazed how few are not using it. We've had sometimes been an hour or so helping them, but some of our team have actually got them working, and they're so excited because then they can ring their kids and their grandkids, and it's been amazing. So yeah, once they've worked out which buttons to push and the cat doesn't walk over the screen, we're right. So that's okay. That's very exciting. I think there's a few things there we might be talking to you about.
Bernadette, is that something I could refer people who were interested, carers who were interested in taking that up? Could I refer them back to Dementia Australia for that kind of support?
Probably not. It's only clients. They're only our internal clients. I don't know that our staff would have capacity to be helping in the sort of general public. I think there's a couple of local councils that are doing that, offering IT support to get people up to speed. And there's a government website called Better Connected. I don't know how much they're doing that. They were doing lots, but I think they've pulled back on that. But yeah, we probably wouldn't be able to take on external. If they became a client and they wanted help, we could do it that way.
Yeah, I think most of our folk are registered with Dementia Australia.
Oh, well, if they're registered with us, certainly. Because anyone that we're trying to contact and they're having issues with their IT, we will link them with one of our staff. So yeah, if they're having trouble, so ask. Yeah, so say if you're with Dementia Australia, just ask for some IT support.
Okay. So thank you.
We're trying to get that, because if they don't do it, it's so much harder to to engage. Yeah.
Deborah, we have 4 care managers on the road, and I did overhear a conversation last week. I think we've got someone who's younger recently. So what's the quickest way? Is there a number that they can call to, if that person, and I don't know the situation, but if they were interested in that YOD support?
Carrington Cafe, it's called.
Carrington. Can we just Google that, or?
Yep, they could call me and then I can have a conversation, explain it, and take it from there.
Okay, I'll just let them know. They may not need or want that, but I'll just let them know. So.
Yeah. So it runs monthly.
Okay. And does anyone know if Kanara House's Talking Cafe has got up and running? I know they were trying to target people with dementia.
Sorry, who's?
Kanara Community House. I connected you, Sarah and Elizabeth, I think via email, so I don't know if anything happened.
No.
Yeah, they were trying to get off the ground right at the start of COVID, though. So
okay.
I haven't.
Well, maybe we revisit that email and re-invite.
Sorry.
If anyone wants to invite colleagues or people from other organisations who are working with people with dementia, please make sure you forward the meeting invite on, we welcome everybody.
I did to a lot of my staff. They all seem to have been pre-booked this week, but certainly I think a few more will come next time. Yeah. So that's good.
You've probably already given it to Brenda through the EDM, have you?
Yes, I would have given it to Brenda. Yep. So, but look, won't hurt to remind Brenda. I think things drop off her email sometimes because she's so busy.
I actually had a question around the younger onset dementia space.
Yes.
Because I was thinking it would be helpful to have somebody speak to that sort of cohort in this group in a couple of fortnights' time, potentially. Does anyone have a name that springs to mind, or somebody? I know we've got Faye Drummond, who works for Bass Care in Canterbury, but I don't know is Kalara House still operating their younger onset program? Does anyone know with each, or Halcyon?
Halcyon, no.
Okay.
No, they didn't get any referrals. All the numbers dropped right down, so she had to close that program. And I know Faye, I got an email from Faye Drummond this week. They're hoping something will start up at the end of October for the YODs. Their new house is ready to be used.
Great.
Okay. Yeah.
And Kalara's younger onset group, I think, is still running, but very much the same story as the other one, the referrals. Because people haven't taken up or have decided not to take up people on NDIS, they've just stuck with their over 65s funding. I think there's a real gap for some of those people in some services. And a lot of the councils have decided to only provide for over 65s, not the under 65s. And as far as I know, there are very few that are doing sort of what we chose to do, which is keeping that little bit of hack younger funding and taking people on NDIS packages as well.
Because I think the other thing is there's a real need for housing options for people with younger onset dementia. So, and I've had a few conversations internally about some support coordination clients that have come through who have NDIS funding, they have a diagnosis of younger onset dementia, and part of what they would like the support coordinator to arrange is sourcing some type of alternative accommodation to the traditional aged care nursing home kind of option.
Not out there.
No.
Not out there. And that's been an issue for a long time. And we've been doing lots of advocacy and it's just not happening. And yet I think there's enough actual numbers to have a few designated specialist YOD facilities. I've had, they're doing specialist facilities for all sorts of things. There's enough numbers. I think what was the number? Is it 9,000 in Victoria?
Yeah, that sounds right.
It's a lot of people, all of whom will need an aged care home one day.
Yes, and I think part of the issue is that it's really difficult to find the data on these people to evidence the establishment of something that is specifically younger onset, because now they don't belong in the aged care space where they were sitting. So a lot of us would have had experience and knowledge and clients who had younger onset dementia, but now it's a separate area. We don't have the information, but I'll work on it. That's in my...
Wasn't Hammond Care putting something together with some organisation, having a space for YOD in an aged care facility?
Yeah, I think that their new care style, which was the Holland Dutch style, I think they were having a unit that might have been a YOD space in their cottages, but I haven't heard any more about that. I don't know.
The last I heard was they were talking about putting something together in New South Wales, I think, that was younger onset specific, but there was no update, so it must have been something.
So if you need a speaker, what area in the YOD? Because I mean, a couple of our staff certainly still specialise in YOD. Or did you want an NDIS YOD person, or are you looking as a different focus for your YOD talk?
Well, look, whatever's relevant to more than just me, I guess, and my queries around it. I know a lot of the younger onset specific stuff has either folded or, people have changed focus because in COVID, there's a whole lot of stuff that's just had to be sidelined or, shelved for the time being. Yeah. So I have quite a few queries, I suppose. We're having referrals trickling through for either carer support of a carer of a person with younger onset dementia, or, you know, the support coordination through our disability arm. And I'm just curious because I feel like I've lost touch with where things are at for younger onset. So I'm just, you know, interested. But I'll ask some questions too, and I'll talk to Faye because it's likely that she would have more understanding around what's relevant now.
Yeah, that'd be good. Yeah, it would be good because I think you're right. The waters are very muddied, and it's because it's just so hard to keep in touch with everything that's going on and changing daily.
And I know we're seeing a lot of carer stress. Yeah, so and nationally across 39 offices, there's been about a 20% increase in respite services.
Yeah.
So I don't know the breakdown between private and the delivery of brokered respite, because there's always the, you know, there's a few $1,000, not many, but a little bit, you know, for on-site support to distract someone or give someone respite. But so it would be a bit of that, but it's also private. There's always that private option. People need it, so that's out there. You know, that's a lot really nationally, including in offices. It's caring for someone would be hard with dementia without lockdown. You know, if it's fairly advanced. So, and I was concerned about a conversation I had with a pharmacist last week that I know quite well. About a third of the elderly clients who had been prescribed antidepressants. And one had attempted suicide. So that's a lot. That's a lot of antidepressants, and I tend to think, is that, you know, did the doctor give them the 1-800 COVID support line for seniors, you know, the dementia support line, that, you know, I wonder whether it's take this tablet, you know, I don't know. It just seems a lot to be prescribed. I'm sure there are other ways.
It's not necessarily the most effective anyway, you know.
No, that's right, from what Ben was saying. Exactly. Yeah.
All right. Well, that's all the questions or suggestions, updates? Yeah. Well, thank you very much. I think that was interesting. That was good having Ben along. And I think, Sarah, do you want to give us preempt the next session in 2 weeks' time, who our guest presenter is?
So next fortnight, we've invited Nan Yu, who's on your screen at the moment, to talk to you about, what was the name of the award, Nan? I'm sorry, I'm on the spot.
Decoding Dementia.
Decoding Dementia Award, and the work he's done developing the My Dementia Companion web app for use by family carers and people living with dementia. So we'll get a sneak preview and a walkthrough, I hope.
Yeah, I can't wait. It'd be great to show you guys and get your feedback. I love, really enjoyed today's session as well. So thanks for inviting me along. And yeah, it's awesome, the work that you guys do and sharing that knowledge. It's I think when I first met Sarah, it was one of the big bugbear I had was, there's just no network of innovators in the dementia space who really want to get together and come up with great ideas and share knowledge and things like that. So yeah, you guys getting together, it's awesome. And yeah, thanks for inviting me along today.
Nan, is that app functional or it's still in development?
No, we well, yeah, give you a bit of a sneak peek then. So we launched our pilot about 3 weeks ago. It was probably so my background, I'm a pharmacist by background, so I'm not a technology person or anything like that, right? And then this was a digital product, and it's probably the worst launch in history ever, because I have no idea what I was doing, because I'm doing all this in my spare time. It's a bit of a charity work. So we launched the pilot 3 weeks ago on social media. Had about 30 or 40 people signing up within the first hour with no advertising. So it was, and then afterwards, what I realized was nobody actually knew what this thing was even about before they signed up, and they managed to all sign up. So I think it's a testament of the problem and the challenge people are having around dementia, the carers. And then a week later, the Department of Health formally did a nationwide announcement for My Dementia Companion as well, which I wasn't expecting. And then that just kind of exploded. So we've got about 200 people using the product at the moment as a pilot. Yeah, just fixing issues as they come up, issues I didn't know you could even have. So it's, we are getting feedback and things like that. So I'm happy to send the link around, but yeah, otherwise we can wait for in 2 weeks' time and yeah, do a live demo and get your thoughts. That'd be really good.
Now send the link so we can promote it. It's really hard. People want to know what they're taking time out of their day for. So if you can send the link, I will promote it around. Some of our organisation are sure to know about it, but I hadn't heard about it.
Yeah, sure, definitely. Yeah. So
Thank you.
yeah, we'll do. We'll send that through. Yeah.
Be great. Thank
Yeah.
you. Oh, that's good. And we want afternoon tea next time too, like the volunteers get.
Oh, it's a very, very easy volunteer afternoon tea where I don't have to provide the tea or the cakes.
That's great.
Very good.
That's good.
Thank you very much. I think that's
Thank you.
Yes, thank you very much, everybody. It's been a great,
Great.
Been very
great
good.
hour.
Okay.
All right, until next time.
Yes. Terrific. Thank
Bye-bye.
you.
Bye-bye.
Bye.
Okay.